Introducing America's Workforce Academy, built by Meta. Paid training, a job, and a path to America's future. Because the future is for everyone. Learn more at meta.com/America's Workforce Academy.
Welcome to the Medical Nursing Podcast, the go-to show for vet nurses and technicians passionate about internal medicine. I'm Laura Jones, a registered vet nurse, all-around medical nursing nerd, and your guide to breaking down complex medical diseases into simple, actionable chunks. Each episode is packed with knowledge and tips that you can start using right away to give even better patient care. So let's get started. Welcome back to another episode of the podcast, or welcome if it's your first time here. You are listening to episode 116 of the Medical Nursing Podcast, where we take complicated conditions and break them down so that you can spend more time caring for your patients and less time with your head in a textbook. Hello, thank you so much for being here for another episode. I know it has been a minute since my last one. I am so sorry. June sort of passed me by. I was incredibly busy. I was away doing lots of speaking. I went to ACVIM Congress over in Seattle, which was wonderful to catch up with so many amazing people and learn lots from everyone while I was there. But of course, with all of that fun stuff has been a lot of time needed to speak and travel, and so the podcast sort of took a little bit of a step back whilst I did that. I'm really excited to talk to you today. I actually wrote this episode from a coffee shop in Seattle, but realised I hadn't taken my microphone over to the States with me to record it, so I've had to wait since being back. Now we can sit down and have a good old chat about it. So in this episode, I'm actually bringing you the first episode in a new focus on the podcast, and that focus is medical nursing revisited. As the name suggests, the idea is pretty simple. We go back to conditions that we think we already know inside out, and we look at them again, but with fresh eyes and the most current evidence. Because the truth is, a lot of what we were taught even just a few years ago has moved on. We are, as a profession, continually learning more and more about the different diseases that we see, and of course, with that, the way that we manage these patients is evolving. And if we don't evolve with it as veterinary nurses and technicians, we're going to end up nursing our patients based on an old version of that disease. It's been a long time since we covered gastrointestinal disease on the podcast, and in 2 years and almost 100 episodes, things of course have changed. And across the next few weeks, we're going to look at some of the GI conditions that we see the most and the new direction that we need to take when managing these patients based on the up-to-date evidence. And today I'm bringing you that updated need-to-know information about one of the most common GI diseases that we see, which is chronic inflammatory enteropathy, or what we used to refer to as inflammatory bowel disease. There are brand new guidelines out on managing this condition, and we're going to be using these to refresh and update our knowledge and also look at where we fit in as nurses and technicians in the management of this often complex disease. So if you don't already have one, grab a coffee, maybe an iced coffee, because it's currently a heat wave in the UK as I'm recording this, and let's get into it. So I want to start by talking about what chronic enteropathy actually is and the impact that it has on our patients. So chronic enteropathy, or chronic inflammatory enteropathy as it's now known, was previously referred to as inflammatory bowel disease, or IBD. We borrowed that term really from human medicine, firstly because it was easier for our clients and our caregivers to understand that disease because they had a condition that they'd heard of in people to compare it to. And secondly, we called it that because we saw inflammation within the GI tract, assuming of course that we'd taken biopsies and sent them for histology. In previous guidelines, the terminology changed from IBD to chronic enteropathy, and the last guidelines before the ones that came out this year were published in 2010, so we're looking about 16 years ago now. And now that terminology has changed again to chronic inflammatory enteropathy, or CIE. Now, chronic inflammatory enteropathies are a group of complex diseases causing GI signs that persist for at least 3 weeks. They're thought to occur due to an exaggerated immune response, and the pathophysiology is multifactorial. So our affected patients are thought to have a combination of a genetic predisposition, a dysregulated immune response, and environmental factors, so dietary or microbiome related factors, for example, that contribute to their disease. We previously subclassified these patients based mostly on their treatment response. So if they responded to a diet trial, we called them as having a food responsive enteropathy, or FRE. If they responded to antibiotics, and we're going to be talking a lot more about antibiotics across the next couple of episodes, then it was, of course, antibiotic responsive. If it responded to immunosuppressants, it was immunosuppressant responsive, and so on and so forth. There's also a non-responsive category, which pretty much does what it says on the tin. So of these conditions, food-responsive enteropathy is the most prevalent. It's thought to affect around 50 to 65% of cases of chronic enteropathy. And patients are classified as food responsive if their signs resolve or significantly improve within 2 to 4 weeks of starting an elimination diet. Also, our patients with food responsive enteropathy are usually younger and less severely affected than patients with other forms of chronic inflammatory enteropathy. I also want to mention protein-losing enteropathy here because it fits in with chronic enteropathy. So we could add a branch subcategory of protein-losing enteropathy to each of these classifications. So you could have a patient with food-responsive enteropathy and protein-losing enteropathy, or immunosuppressant responsive enteropathy and protein-losing enteropathy, for example. And that's because protein-losing enteropathy, or PLE, is not a primary disease in itself, but it's a consequence of the patient's underlying gastrointestinal disease. In PLE, serum proteins, so proteins in the bloodstream like albumin and globulins, for example, will leak out of the bloodstream and they become lost via that diseased GI tract. Our affected patients have hypoalbuminemia and potentially panhypoproteinemia, so not just albumin that they're losing, but other proteins from the bloodstream as well. And alongside this, they often have associated clinical signs such as edema or ascites because of that loss of colloidal oncotic pressure from the low protein levels. So all of this works as a framework, yeah? So the way we categorise these patients, food responsive, immunosuppressant responsive, and then protein losing on top. But the problem with this is that this classification is retrospective. So we only really know where our patient fits in after we have trialled treatment. The other problem with the way that we used to do this was that one category, antibiotic responsive enteropathy. And actually this is perhaps a bigger problem, and it's one where the research has really moved on. For a long time, antibiotics have been overused in GI disease, particularly within diarrhoea. In fact, in the Medical Nursing Academy just a couple of months ago, we actually hosted a webinar on this topic. We looked at studies that showed that metronidazole is still the most commonly prescribed out of all the antibiotics that are out there, and it's currently prescribed in the most in, you guessed it, gastrointestinal disease. Drugs like metronidazole and tylosin have been used in the management of diarrhoea for a really long time. And you could even argue that the fact that we used to call a form of chronic enteropathy antibiotic responsive might even subconsciously reinforce the early use of these. And yes, antibiotics may well still have a place in certain cases, but now what we know about the GI tract, and in particular the microbiome, is changing. And of course, if that's changing, so too are the recommendations about antibiotic use. So that's where we were. What's happening now? What has changed in the way that we manage chronic inflammatory enteropathy in 2026? Firstly, the term itself has changed. IBD is most definitely out. It kind of already was, but we often still hear it thrown around in practice. I was at ACVIM last week and was hearing IBD regularly mentioned in talks, for example. So IBD is definitely a term we have moved away from, and chronic enteropathy is in. And alongside this, the way that we classify these patients has also changed. So now we actually have a 2-tier system based on clinical assessment. So we describe our patients as either having chronic enteropathy 1 or chronic enteropathy 2. So CIE 1 is the milder presentation. These are the dogs that have a low chronic enteropathy activity index score, they have no lethargy, no weight loss, their appetite is normal, and their physical exam is unremarkable. These patients are the ones who are bright, who are eating, and have very mild clinical signs. CIE 2 is the more significant presentation. These are probably the ones that we all classically think of when someone says chronic enteropathy or IBD. These patients have a higher clinical score. They generally have weight loss of 5% or more, a poor appetite, abnormal examination findings, or a longer duration of signs. They can also be hyperalbuminemic, but not always. So of course, out of the two of these, our CIE2 patients are the ones that we are more worried about, and also they're the ones where a more extensive workup is going to be indicated. Now, this categorisation isn't another thing for us to remember, but instead it highlights the importance of us considering how severely the disease is impacting each individual patient before we plan next steps. Because not every patient is affected with chronic enteropathy in the same way, and every single patient needs to be approached with that in mind. So we have CIE1 and CIE2, and then on top of that, we still retrospectively classify patients based on their treatment response. So food responsive, immunomodulatory responsive, and non-responsive. Now you'll notice there that one category is missing, and that's because we have got rid of antibiotic responsive as a disease process in itself. Because with the benefit of evidence, we now know a lot more about how antibiotics really affect the gut. And the way that we have changed this classification, the way that we have changed how we approach CIE really reflects our better understanding of what's actually going on for that patient. Because we know CIE is multifactorial. It involves the immune system, the gut microbiome, environmental factors including diet, and genetic susceptibility. Dysbiosis, which is that disruption of the normal bacterial population in the gut. There are other pathogens as well, not just bacteria, but for ease, we'll say bacteria here. Dysbiosis is well documented in these patients, along with changes in things like how bile acids are handled within the GI tract. Now, we're going to actually talk more about the microbiome in a separate episode because it's a huge topic and I want to dedicate a single solo episode to it, but it plays an enormous role in how we manage these patients. We also need to look at how we play a role in chronic GI patients as veterinary nurses and technicians because our role is huge. We can do a lot more with these patients than we have been able to up until this point. But of course, we are not going to be directly diagnosing these patients as veterinary nurses and technicians. This is outside the legal scope of our role. That being said, we still play an essential role in the process. We're going to be doing things like processing samples and supporting patients during imaging, setting up for and managing endoscopy cases, supporting patients during endoscopy under anaesthesia. All of this, our role really cannot be overlooked in the care of these patients. And this means that we need to know how these patients are diagnosed. And the most important principle within this is that CIE is a diagnosis of exclusion. This means we don't necessarily have a test confirming that our patient has chronic inflammatory enteropathy. Instead, we need to rule things out step by step and see how the patient responds to treatment trials. This can be quite a long process for our caregivers. And so for us as nurses and technicians, one way that we can help with this is by educating and supporting them and helping them manage expectations. So we need to understand how that diagnostic process plays out. The first thing that these patients need is a physical assessment. This should include a diet and medication history, a comprehensive examination, body and muscle condition scoring, and a clinical score. To do this, we use something called the Canine Chronic Enteropathy Activity Index scoring system, or the CCEAI. I will leave a link to that scoring system in the references in the show notes for you as well if you want to have a look at that. Alongside that initial assessment, routine diagnostics are typically performed, and these include a comprehensive biochemistry, including electrolytes, a haematology, a urine analysis, and typically a fecal examination. From here, we need to think about further testing. So this testing is going to include malabsorption profiles, so things like TLI, B12 and folate, basal cortisol levels to screen for Addison's disease, maybe a pancreatic lipase, and also other diagnostics as required. Imaging is also usually performed, and depending on the individual patient and clinician preference, this is usually an abdominal ultrasound plus minus thoracic radiography as needed. Then the next step after this is a diet trial. So in a stable patient who is eating, a diet trial is the preferred first diagnostic step. So this means we are not rushing a stable, happy CIE1 patient into something like endoscopy and biopsies. Instead, we see how they respond to an appropriate elimination diet or diets, because many cases we might need to think about different options. If one diet hasn't worked, we try another one. Now, this diet trial is really important because between 38 and 89% of dogs with chronic enteropathy, depending on which studies you read, are food responsive. Many also will stay in remission on diet alone long term with no other medication at all. So diet trials are essential, but it's also essential that they're done properly because they are easy to get wrong, and providing caregiver education and support is a key factor in getting them right, and that's where we come in as nurses and technicians. A true diet trial is where we feed a single therapeutic diet exclusively for at least 2 weeks. That diet is chosen based on the dog's history and signs. It might be highly digestible, it might be a novel protein, so one which the patient's never been exposed to before. It might be a hydrolyzed protein source, so where the protein is broken down into building blocks, so amino acids. It might be low fat, it might be fibre enriched. It all depends on the individual because different categories of diet suit different patients. Ideally, we would try at least 3 different diets if the first doesn't work, which is why our role in supporting with this really cannot be overstated. Trying to get a client to feed only one diet, so no table scraps, no treats, no nothing, just that diet for at least 2 weeks is hard enough. But the potential of them having to then do that again and maybe even once more after that can easily be off-putting and impact compliance significantly. But the reality is that we as nurses and technicians are the ones who can explain why exclusive feeding is so important. We can sit down and we can problem solve people with multi-pet households, or people who have kids that feed scraps under the table, or an elderly neighbour that gives biscuits over the fence. We are the ones that can help create the feeding plans, do price comparisons to show that the diet we're advising isn't as expensive as it seems, and of course we can help create a nutritional plan that works for them and for their pet. And this is important because if our diet trial fails because of poor compliance, it's not just the time that has been spent doing that diet trial that has been wasted. The worst case scenario is our patient ends up having to have a general anaesthetic, endoscopy and other interventions and treatments, which we could have avoided if a different diet trial had been performed or if a diet trial had been stuck to more properly. So supporting with this is a really, really important part of nursing these patients, much more so than it might initially seem. If a diet does resolve the patient's clinical signs, we need to feed this for at least 12 weeks before anyone tries to move away from it. Because managing expectations is an important part of improving treatment compliance. Part of our job is making sure that our clients and caregivers know that this will be a long process rather than a quick fix. But if they take the time to do it properly now, it will ultimately be worth it. But of course, not every patient is going to respond to just a diet trial. If that was the case, we wouldn't be doing half as much gastrointestinal endoscopy as we currently are. So if a dog has failed properly run diet trials, or if they are clinically unwell and it's not appropriate to wait and see how they respond, then of course endoscopy and biopsies are going to be indicated. I'm actually going to be running a whole endoscopy series after this GI one because you guys have been asking for it, so I'm really excited to bring that to you. So with that in mind, I am only going to touch on endoscopy very briefly during this episode. Put simply, we need to both visualise the GI tract in a minimally invasive way and collect multiple good quality diagnostic samples that we can send off for histology and maybe culture as well, depending on the individual patient. We usually either scope the upper GI tract, which is the esophagus, the stomach and the duodenum, the lower GI tract, which is the ileum and the colon, or both, depending on the individual patient and their clinical signs. For us as veterinary nurses and technicians, our role is vast and it includes things like preparing the equipment, assisting with use of the scopes during the procedure and maintaining them. It includes proper patient positioning, preparation and support during, before and after the procedure. It includes anaesthetic planning, maintenance, monitoring, and it includes things like handling, preparing and submitting samples for analysis. Now, as I said, we're going to go into scopes in much more detail. There will be a dedicated episode on GI endoscopy. But one thing that I want to mention is that many patients that undergo GI endoscopy are higher anaesthetic risk. Because if we think about it, they have things like dehydration from ongoing vomiting or diarrhoea, hypoalbuminemia if they've got protein-losing enteropathy, and poor body condition. So careful anaesthetic planning and support is absolutely vital. During the procedure, around sort of 6 to 15 biopsies should be collected from each area, depending on the specific area itself. We need to be careful when collecting these biopsies to avoid tissue damage or artefacts, and also this is a risk that continues for us as nurses and technicians when we are handling and mounting these samples in the little cassette to go in formalin. Any artefacts that happen will limit the diagnostic quality of the samples and ultimately the information that they give us. So even though submitting the samples seems like a really simple thing, it's actually really important. This episode is brought to you by the Veterinary Internal Medicine Nursing On Demand Library Club. And honestly, if you are not already a member, then you're going to want to hear this. For just £21 a month, you get access to the entire Veterinary Internal Medicine Nursing webinar library. That is over 60 hours of CPD, and it's growing month on month on all things internal medicine nursing, and it's available on demand whenever you need it. And it doesn't stop there. Every single month you get a brand new webinar too, plus access to the monthly evidence files live sessions all included. Whether you want to deep dive into a specific topic or just keep your CPD ticking along, the Library Club makes it ridiculously easy for you to do so. There's no contract, you can cancel anytime, and if your clinic gives you a CPD budget, I can even invoice them directly for a yearly subscription. Think of it as your own personal library card for veterinary nursing education. Head to veterinaryinternalmedicinenursing.com and check out the Library Club to grab yours. The link is waiting for you in the show notes. And now, back to the episode. And then after diagnostics, we need to think about treatment and management. This treatment includes things like diet, microbiome management, and immunomodulatory drugs, depending, of course, on the individual patient. So the first thing we're going to look at is how to select an appropriate therapeutic diet for a dog with chronic inflammatory enteropathy. The first thing to say is that the optimal diet will always depend on the individual patient. In general, we use limited ingredient or hydrolyzed protein diets in most patients that have chronic inflammatory enteropathy. Patients that have syndromes like lymphangiectasia, which is the dilation of the little lymphatic vessels that run in the gut, or who have protein-losing enteropathy will actually need a low-fat diet. And some patients require manipulation of things like soluble dietary fibre. It all depends on both the specific clinical signs for that individual patient and their diagnostic results. Even if we end up adding medication on top, we need to continue feeding the diet that helps improve the patient's clinical signs, because it may allow for things like lower drug dosages, or it might even enable us to discontinue some medications completely further down the line, all depending, of course, on the individual. The next thing, and the thing actually that's changed the most, is the role of antibiotics and the microbiome. The first most important point that I want to emphasise is that empirical antibiotics are not recommended for these patients. The reason for this is that the evidence shows that dogs tend to relapse soon after the antibiotics stop, and also antibiotics cause long-lasting disruption to the gut microbiome, to the bacterial flora, so they can actually make that underlying problem worse. Instead, we reserve antibiotics for cases that have failed everything else, unless the patient has one specific form of GI disease, which is granulomatous colitis. So GC, or granulomatous colitis, is a form of chronic, usually severe, large intestinal disease, which is linked to a specific invasive form of E. coli bacteria. Because it's caused by invasive E. coli, this disease does, of course, need an antibiotic. It's usually a fluoroquinolone. It should be guided by culture and sensitivity from biopsy samples because resistance is common. And this is the only exception to early antibiotic use. So in routine cases, their use is contraindicated. And of course, yes, I'm talking about antibiotics here. And I know that we as veterinary nurses and technicians are not going to be making prescribing decisions. However, we may well find ourselves in situations where clients are asking us for them or questioning why they haven't been used. And so we're probably going to have those difficult conversations. It's really helpful here for us to explain why this is. So by explaining that avoiding them is a better choice for the gut, and we are deliberately choosing not to use them, we can often stop these client frustrations really, really quickly. So if antibiotics are out, we need to think about what we're going to use instead. And actually, we're shifting that focus from antibiotic responsive to microbiome responsive. So we need to focus on supporting the microbiome. This is usually achieved using things like prebiotics, probiotics, and symbiotics. So very, very briefly, probiotics are the actual bacteria, the good bacteria. They're in, your Yakult or whatever, fermented drink thing that you have in the morning to be healthy. The prebiotics are the food for the bacteria in the gut, and symbiotics are medications that include both of those things. So lots of commercially available probiotics have prebiotics within them, so they are actually symbiotics. FMT or fecal microbiota transplantation is also an increasingly used treatment for these patients because it's easy, it's cheap to perform, it's well tolerated, and it has good results. And this is definitely something that I am seeing us do a lot more of in internal medicine. Now, we are going to talk more, as I said earlier, on microbiome and also FMT in a future episode because it plays a bigger role in GI disease than I think we have all previously appreciated, and it deserves its own episode. And then we also have immunomodulatory treatment. So our immunomodulatory drugs are drugs which regulate the immune system, and these are used when patients have not completely responded to a diet trial. Usually the first drug we try is everyone's favourite drug in internal medicine, which is glucocorticoid steroids like prednisolone. You can also use budesonide, which is another treatment. This can be useful where patients are displaying severe side effects on pred. So if they're really PUPD, and it's becoming unmanageable for the clients, there are other steroids that can be used at the clinician's discretion. Some patients will actually not respond to steroids alone, and they will need to have a second-line agent added on top. So this is things like chlorambucil is one we use commonly, also cyclosporin can be used as well. Many second-line agents are firstly off-licence depending on where you are in the world, secondly cytotoxic, meaning that they're going to require special handling and care. And for us as nurses and technicians, a big part of our role is going to be on advising with this and supporting clients with this. Alongside this, wider education and support is a big part of nursing these patients. Our clients and caregivers need to know what side effects they should expect with treatment and how to monitor for those. And we're also going to need to give them tips on managing things like PUPD at home, for example, if you've got a patient on high doses of steroids. So things like avoiding giving the medication in the evening if at all possible, if you want to try and get more of a decent night's sleep and not be, up in the middle of the night letting the dog out to the toilet, that sort of thing. And throughout all of this, on top of that, the client needs to continue feeding that diet that's working. Other treatments include B12 supplementation when levels are low. Now, interestingly, we used to use parenteral injection. So you guys, well, I'm sure have done the same where you've got patients coming in for their weekly B12 shot, and then after 6 weeks or so, that frequency tends to decrease. But interestingly, recent evidence shows that oral dosing works just as well, which is great because actually for some clients, coming in every single week for an injection might seem like a hurdle, which to them impacts their decision to carry out treatment. In some cases, we may also have to think about things like folate or vitamin D supplementation, again, all depending on the individual patient and the prescribing clinician. And if you're managing a patient with protein-losing enteropathy, they also will often be prescribed antithrombotics. And the reason for that is their protein loss puts them at a significantly higher risk for thromboembolism because they lose some of the proteins that prevent clots from forming unnecessarily. So this means for us, careful monitoring for signs of thromboembolic disease is an important part of nursing these patients. Lastly, I want to talk about the monitoring that our patients with chronic enteropathy need. Interestingly, regular monitoring is highlighted in the new guidelines, and in fact, their advice is that these patients are initially reassessed every 1 to 2 weeks. And I think that this presents a huge opportunity for us to do more in the long-term care of these patients as veterinary nurses and technicians. The monitoring that is recommended for these patients includes weight, body and muscle condition score assessment, as well as a quality of life assessment, a chronic enteropathy clinical score, and checking for medication side effects. And these are all things that we can assess in something like a nurse-led or technician-led consultation. So if you are not doing these in your GI patients, now is the time to start. So I want to finish off by just briefly recapping everything we've discussed because it has been a lot. And with this, there's lots more that we can do as nurses and technicians in the management of these patients. So the most important changes in chronic enteropathy are how we classify and manage it. We call it CIE now, not IBD. It's classified as either CIE 1 or CIE 2, depending on whether the patient is clinically affected or not. And then after that, by what it responds to, either food responsive, immunomodulatory responsive, or non-responsive. Antibiotics have very much fallen out of favour. Instead, we want to protect and support the microbiome unless we have a clear, specific case for antibiotic use. And diet is essential. And this is something that we don't just use for therapeutic purposes, we use it as a diagnostic tool as well. So we can assess how these patients respond to diet, and that gives us diagnostic information. But above all, veterinary nurses have a much bigger role to play in the management of these patients. Nutritional assessments, body and muscle condition scores, dietary history collection, endoscopy assistance, education, support, I could keep going on and on and on. All of this is an essential part of our role. And that means that we get to use our skills and our knowledge all while making a significant difference to our patients and their families. So that is everything that I have for you this week. Thank you so much for listening to another episode of the podcast. Of all of the podcasts out there, I really appreciate you choosing to learn with me today. You can grab the updated guidelines in the show notes if you want to read them for yourself. And if you found the episode helpful, the very best way that you can support me as a creator is to follow the podcast on the app that you are listening to me on right now and leave a rating or review. This really helps me grow the show, help more vet nurses and technicians learn, and help more people help their patients. Huge thanks again for listening. Keep using your skills and supporting your patients, and I look forward to speaking to you very, very soon in a future episode. Bye. If you've made it this far, then thank you so much for listening all the way to the end of the episode. And I have one more thing to ask of you before you go today. I would love to hear from you. Yes, you. I love hearing about the cases that you're seeing, the skills that you're using, and the conditions that you want to learn more about. Drop me a DM on Instagram. I'm at Vet Internal Medicine Nursing, and don't be shy. Come on over, say hello, and tell me a bit more about you. Talk to you soon.